Hello, my name is Donna Volpe, and this is my surveillance presentation on the Zika virus. So in this PowerPoint, I'm going to talk a little bit about the background of the Zika virus, surveillance questions and their significance, two research studies which present data that suggest two possible correlations, namely Guillain-Barré syndrome and microcephaly, limitations of the studies, conclusions and next steps in research, and I've included reference slides. Background. The Zika virus is a member of the virus family Flavividae and the genus Flavivirus. There are two types of Aedes mosquitoes capable of transmitting the Zika virus. In most cases, this virus is spread through the Aedes aegypti mosquito in tropical and subtropical regions. The Aedes albopictus mosquito also transmits the virus and can hibernate to survive in regions with cooler temperatures. These two mosquitoes are also responsible for transmitting chikungunya, dengue, and yellow fever. The Zika virus was first identified during primate surveillance of rhesus monkeys in the Zika forest in Uganda in 1947, so that's how it got its name. By 1952, the virus was identified in humans in Uganda and Tanzania. As an arboviral disease, which means the virus is transmitted by arthropod vectors such as mosquitoes, the Zika virus is nationally notifiable. Although the virus is mild in nature, newly reported locally transmitted cases in French Polynesia in 2013 and Brazil in 2015 resulted in a cluster of persons diagnosed with Guillain-Barré syndrome, or GBS, and newborns born with microcephaly, generating national concern. To date, 40 countries have reported local transmission of the Zika virus, while 12 others have reported the virus without vector transmission. GBS, or Guillain-Barré syndrome, is an uncommon disorder of the nervous system in which a person's own immune system damages the nerve cells, while microcephaly is a neurological disorder which the occipital frontal circumference of the head is smaller than that of other infants of the same age, race, and sex. As a result, on February 1st, 2016, the World Health Organization declared a public health emergency of international concern to encourage prevention of international spreading of the Zika virus. Risk factors for the Zika virus include travel to endemic areas, mosquito bites in these endemic areas. The mosquito is known as an aggressive day biter, so being out during the day adds to the potential of being bitten. Water sources. The mosquito breeds in standing water, so lower elevation areas near water would be a risk factor. The risk of getting infected is likely to be minimal at elevations above 6,500 feet because mosquitoes are largely absent from this area. And sexual intercourse with an infected person is also a risk factor. Surveillance question number 1. Where has the Zika virus been found? As of February 26, 2016, 40 countries and/or territories have reported local transmission of the Zika virus. 12 other countries, including the United States, have confirmed cases of the Zika virus from travel or sexual transmission. The significance of this is that the Aedes aegypti has spread most Zika cases, but this mosquito is also common or indigenous to the United States in such states as Florida, the Gulf Coast states, and in Hawaii, although it has been found as far north as Washington, D.C. in hot weather. Surveillance question number 2. When do people become aware they are infected with the Zika virus? 1 in 5 people with the Zika virus usually become symptomatic, so it's hard to establish a clear incidence of the infection. Symptoms of the virus include fever, rash, conjunctivitis, joint pain, and headache, which can last several days to weeks. Diagnosis is primarily based on the detection of viral RNA from specimens in acutely ill patients, but it may also be found post-onset by detection of Zika-specific IgM antibodies. So significance is the incidence of the Zika virus infection is often correlated to an associated complication, such as microcephaly or Guillain-Barré syndrome. Based on this method, the incidence of the Zika virus infection is increasing. As of November 2015, it is estimated that 99.7 cases per 100,000 live births of infants displaying microcephaly could be attributed to the Zika virus. This is a 20-fold increase from a 2010 report which listed 5.7 cases per 100,000. Surveillance question number 3, who can be infected with the Zika virus? Any gender, age, or race can become infected, most commonly through a mosquito bite, but it's also often also postulated that the person can become infected with the virus through sexual intercourse with an infected person, intrauterine and perinatal transmission, blood transfusion from an infected person, or breast milk. The Zika virus is primarily transmitted to people through the bite of that infected Andes mosquito. However, the virus has been detected in blood, urine, amniotic fluid, semen, saliva, as well as body fluids found in both the brain and spinal cord. While anyone can become infected with the Zika virus, what makes this virus stand out from other mosquito-borne illnesses is the effect it appears to have on pregnancy. The virus can spread from a pregnant mom to her fetus, and that infection during pregnancy may suggest some link to birth defects. This is a depiction of an epidemic curve of countries and territories reporting the Zika virus transmission either locally, through travel, or sexual transmission from 2012 to February of 2016. So I constructed this to take a look at the virus's time trend and depict a sense of the illness's magnitude. You can see where it began and then it went up, and hopefully we will find that the territories reporting the Zika virus transmission will go down. I chose to concentrate on 2 important studies in 2 different nations, French Polynesia and Brazil, as research about the Zika virus is ongoing. So the Zika virus and Guillain-Barré syndrome study. French Polynesia would see typically 3 to 10 cases of Guillain-Barré syndrome in a year. During the Zika virus outbreak, however, 42 patients were diagnosed with Guillain-Barré syndrome in the span of 4 months. Clusters of cases of GBS are quite unusual. In a 2016 case control study by Cal Lormier et al. In French Polynesia, 42 Guillain-Barré syndrome cases were identified during the 2013 to 2014 Zika outbreak. 88% of those reported an illness compatible with the Zika virus infection. A retrospective analysis, which included seroneutralization testing, demonstrated that all 42 cases were positive for dengue and Zika virus infection. In 2015 through part of 2016, similar increases of GBS were noted in Brazil, El Salvador, Colombia, and Venezuela. This is a graph depicting the weekly cases of suspected Zika virus infections and Guillain-Barré syndrome in French Polynesia during the outbreak, which occurred between October 2013 and April 2014. The darker columns are the number of Guillain-Barré syndrome cases, while the lighter ones are the number of suspected Zika clinical infection cases. The bottom is the date of illness onset, which are divided into epidemiological weeks. The second study that I looked at was the Zika virus and microencephaly study. So in a 2015 through 16 cohort study by the New England Journal of Medicine, recently out, researchers found that 29% of 88 Brazilian women who had ultrasound exams after testing positive for infection with the Zika virus had fetuses that suffered grave outcomes, including fetal death, tiny heads or microcephaly, shrunken placentas, and nerve damage. Outcomes occurred in all 3 trimesters of pregnancy. This study, which is still in progress, followed 88 pregnant women who visited a fever clinic at the Oswaldo Cruz Foundation Hospital in Rio de Janeiro, one of Brazil's leading research hospitals, between September and February. Every woman with a rash, which is the most characteristic symptom of the Zika virus infection, were tested for the Zika virus, and 72 were positive. The tests looked for the virus itself. This is a spot map which focuses on place by showing on the right each case in Brazil of both the Zika virus as well as microcephaly clusters. So you'll notice on the right there in the magenta colors, those are microcephaly rates by state in Brazil in 2015. The larger circles are 100 cases per 100,000 live births. Between 2001 and 2014, an average of 163 microcephalic cases were recorded in Brazil annually. Between October 22, 2015 and February 20th, 2016, however, a total of 5,640 cases of microcephalic and/or neonatal malformations were reported by Brazil, including 120 deaths. Excuse me. Results or hypotheses generated. In the GBS study, 24 out of 100,000 people infected with Zika virus developed Guillain-Barré in French Polynesia during the outbreak, compared with a global incidence of 1 to 4 per 100,000 persons annually. This is the first study providing correlation between GBS and the Zika virus. Results for the microcephalic study. 88 women were enrolled. 72 women, or 82% with a rash, had positive results for the Zika virus on PCR in blood, urine, or both. 16 women with no rash were placed in the control group and had negative results for the Zika virus. 42 of the infected women agreed to have a series of ultrasound scans, as did all 16 uninfected women. Of the remaining 30 infected women, 2 miscarried and 28 declined the scans, citing distance to the ultrasonographer. Of the 42 infected women receiving regular ultrasounds, a dozen had babies who died in utero or suffered serious birth defects. Only 8 of the babies carried by the 42 women have been born so far, but the ultrasound scans for them turned out to be accurate. None of the 16 uninfected women had problems in their scans. Conjunctivitis was present in 58% of Zika-positive women, which suggests there may be a clinical feature. Important limitations. For the Guillain-Barré study, it was a small sample of 42 participants. The population is fairly homogeneous, and many had prior exposure to flaviviruses. For the microcephaly study, again, a small sample size of 88, and the study does not answer whether Zika infections, so mild that they produce no symptoms in the mother, can damage a fetus. Conclusions and next steps. Although strong epidemiological data suggest the association between the Zika virus and GBS, a causal link between the virus and this condition is still lacking. More studies are needed to investigate the association of the Zika virus infection and GBS. Also, are there other neurological defects related to the Zika virus infection? Or is there another cofactor involved, such as malnutrition or other concurrent infections? The Zika virus infections have been confirmed in infants with microcephaly. However, it is not known how many of the microcephaly cases are associated with the Zika virus infection. Although the Zika virus has been detected in the pathologic specimens of fetal losses, it is not known if the Zika virus caused the fetal losses. More studies are needed to investigate the association of the Zika virus infection and microcephaly, including the role of other contributory factors, such as prior or concurrent infection with other organisms, or the role of nutrition and the environment. The full spectrum of outcomes that might be associated with the Zika virus infections during pregnancy is unknown and requires further investigation. In addition, there needs to be a rapid testing to detect the Zika virus. Here are my references, and thank you for listening.